Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting.
And I'm Dr. Maria Bolton, GP and former President of the Australian Medical Association of Queensland.
We're coming to you from Meanjin, the land on which this podcast is being recorded. Today we welcome Dr. Melanie Allan to sMater.
Melanie is a gynaecologist at Mater, specialising in fertility, gynaecology, menopause and adolescent gynaecology.
Melanie, welcome to sMater.
Thank you very much.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Today we're going to be looking at the federal government's $573.3 million women's health package, particularly around menopause, and obviously very keen to hear your thoughts in just a moment. But before we do, just a reminder of what Prime Minister Anthony Albanese had to say when it was announced.
Too often, women's health hasn't been taken seriously. Something had to change. We're investing more than $500 million to make sure that it does. So we're making new contraceptive pills cheaper. We're funding more free GP appointments for long-term contraceptives like IUDs. And we're boosting support for women experiencing menopause. We've already opened 22 new endo and pelvic pain clinics to help women get treatment sooner, and we'll open 11 more. Australian women have asked for change. We've listened and we're delivering that change.
Let's start with the menopause funding, and that includes 3 menopausal hormone treatments becoming available through the Pharmaceutical Benefit Scheme. Can you tell us what are the therapies and give us a brief breakdown on what they are?
Okay, so the 3 therapies are Estrogel, Prometrium, and a combination of the 2, Estrogel Pro. And these are more newer medications, and they are biosynthetic medications, so more similar to the hormones that we produce ourselves in our body. Estrogel is to replace any lost estrogen, and that's applied on the skin and absorbed within about 20 minutes. The Prometrium tends to be taken orally, and then the other one is a combination of the 2. And these are really exciting ones because they are those bioidentical medications. Then we're seeing less side effects with them and more advantages with them for women. And the Prometrium, the micronized progesterone, it's been a choice of a lot of menopause providers for a long time, but that financial implication has been really quite inhibitory to getting their patients the best sort of medication for them.
Cost is an issue, as we know, especially at the moment where there are cost of living pressures.
Yes.
And it is great to see these medications come into the PBS. They're long overdue. What do you think is going to be the impact for women in the community?
So I think the impact will be huge. I think that women bear the additional financial burden of looking after reproductive health, from contraception all the way up to looking after menopause therapies. And it's often a really demanding time in their life. They're hitting their peak with their career. They can be caring for elderly parents, looking after children at the same time. And to be able to not be able to focus on their health so they can then be well enough to do everything else, and that they have to make financial considerations when they've got these symptoms that they're really struggling with. I think that's a massive plus to be able to access this healthcare appropriately and readily.
In terms of hormone therapies, and just bearing in mind that we're discussing this with 4 GPs as an audience, what are the latest options available? What is the safest option? And when choosing what to prescribe to a patient, does availability come into play? Because we know that there are some options that perhaps aren't available at the pharmacy.
Yeah. And I think, the production capacity has increased in Australia. I know from my time in the UK as well that often there wasn't that access to the menopause medication. It was prescribed, but it wasn't there. I think these 3 medications that we've highlighted are really important ones. Those ones where we're delivering estrogen through the skin, either in patches or gels. Then we're really reducing that prothrombotic risk, that risk of making blood clots in women. So that's a lot safer way to do it. We're missing out sort of liver metabolism and things like that. Also, these the Prometrium, because it is that bioidentical progesterone, it doesn't seem to have as high breast cancer risks associated with it. It seems to be better for promoting sleep, which can often be a problem during menopause. So it does have a slightly sedative effect, so it's advised to take it at night time. And we've been waiting for the micronized progesterone because it does have all these advantages and less of the risk. So I think these three are, as well as other topical estrogen prescriptions, they look like they're safer, there's less cancer risks associated with them, and they will help support women during this busy time in their lives.
Any tips on how to apply the gel?
I'm speaking to you from Queensland. It's hot, it's humid, and I think trying to find 20 minutes of your day when you're not going to be hot and sweaty, it can be quite challenging compared to other areas of the country. So I'd probably just either often after the shower, when perhaps you can dry off and you're cooler, and just sort of trying to apply the gel over one of your limbs, it doesn't matter which, and letting it dry. It's also important that other members of your family don't come and touch your skin during that time. So we don't want that estrogen transferred to partners or children at that time. So it might be a really difficult challenge for some people to have 20 minutes by themselves after they've had a shower, but that would be an ideal time to do it. With things like patches, then obviously that just pops on. That's not going to go into contact with everyone else. But again, in our climate, when it's quite sweaty, it may be difficult for those patches to stay on.
How important is that to reinforce that with patients? I'm thinking personally, I'm not waiting 20 minutes and now you're making me feel terribly guilty.
Yeah. Well, I'm sorry about that. I think we're all trying to squeeze in a bit of time to ourselves in the day. Perhaps then trying to put that gel on just before you go to bed when everyone else is settled. You've got to make it work with your home life, and to just make sure it is absorbed properly and doesn't get transferred to other people.
Most women reach menopause between the ages of 45 and 55. The Australasian Menopause Society reports that in Australia, the average age for women to reach menopause is 51, but some women can reach menopause as late as 60.
Now, from the 1st of July, new Medicare rebates will be available for menopause health assessments, which are designed to help women experiencing menopause and perimenopause symptoms, help them receive higher rebates when accessing care. So can you talk us through those health assessments and what they involve?
The Australian Menopause Society has produced some fantastic guidelines for us and for our GP colleagues, and there's a great menopause toolkit, which kind of gives you a step-by-step what you should be asking your patient when they come in, what stage are they in their reproductive or post-reproductive journey, and what tests are useful and what other things we should be thinking about. When women come in to see you, was thinking about there's their general health. We know at this time in their lives that they're going to be increased risk of cardiovascular disease. There's also when the estrogen goes down and we're thinking about protecting their bones. As we going through this stage of life, is there a risk of developing type 2 diabetes as things like obesity might come on board? And with my obstetrician's hat on, having looked after women during pregnancies, when I see people with preeclampsia, high blood pressure, with diabetes in pregnancy, I know that they carry an additional risk of these things coming along. And this is the time in their lives where the diabetes and the blood pressure might start to show up. So doing an HbA1c, checking on their cholesterol, checking on their general cardiovascular health, sort of a well woman check, as it were. Also thinking about, are there any contradictions to them being on the HRT? Is there any personal history of breast cancer? Have they had a hysterectomy? Other factors have they had a stroke or a blood clot in pregnancy, for example, in the past? I think pregnancy gives us a really nice window into what things we might need to look out for in this period of their life.
The important thing about the health assessments is that it's going to allow us to spend more time with our patients because of the increase in the rebates, which is really valuable. And one of the questions that we're always asked is weight.
Yes.
Because women can put on weight around this time, particularly around the middle.
Yeah.
Do you have any advice that we can share with our patients regarding weight?
We know that muscle mass decreases from the age of 40 onwards, a certain percentage each year. And thinking about those weight-bearing exercises that we've got, building that muscle mass, we're raising the metabolism. So that's sort of working in the background. We also think about weight-bearing exercise. That increases our bone health as well if we're doing those sort of higher impact things, age-appropriate, joint-appropriate exercises as well. Again, going back to pregnancy, women that have gestational diabetes, they tend to follow those low GI diets with those slow release energy so that you're not getting those peaks and troughs of your sugar. And then, you get to 5 o'clock in the afternoon, you've skipped breakfast, you've had a light lunch, and you're just craving something really sugary at that time. A lot of women don't have enough protein content, and that's an important thing to be considered. It fills you up for a long time, and it's a good source of energy during this stage of your life.
We haven't seen the detail on the health assessments yet, but wouldn't it be really useful if, as part of that, we could use a chronic disease care plan where women can access subsidised access to dietitians and exercise physiologists? And
absolutely.
I guess the devil will be in the detail.
That would be really helpful to take that multidisciplinary approach for something that's a very big problem, impacts our economic workforce. It's huge. And if we make those small interventions at the beginning of menopause and guide that journey more smoothly, then we will be more productive.
You mentioned some of those risk factors to keep an eye on before. Are there services or other specialists GPs can refer menopausal women to should they have any of those concerns? There are women, for example, who have a personal history of breast cancer or who may be experiencing menopause symptoms.
Yeah, I mean, certainly at the sMater, we will see women with menopause. And beyond that, sort of for looking for referrals out in the community, someone who has a background in reproductive health, perhaps a CREI trainee, is someone who has got a very deep understanding of reproductive hormones, and they'll be able to they'll be able to really help with those specialist cases. And we're talking about people who want to extend their HRT beyond 5-10 years' time. We're talking about people who want to start HRT later on in life, and also people who've experiencing a lot of symptoms after breast cancer or maybe removal of ovaries as well. And those can be really challenging cases because a lot of the estrogen and the progesterone isn't suitable for those people, and we need to think about other types of medication as well.
Perimenopause usually begins in the early to mid-40s and, on average, lasts 4 to 6 years. According to the Jean Hales organisation, around 20% of women have no symptoms, 60% experience mild to moderate symptoms, while the remaining 20% have severe symptoms that interfere with daily life. In addition to symptoms such as hot flushes, headaches and changes in mood, the Australasian Menopause Society also reports around 2/3 of women have memory problems and reduced processing speeds.
When is the best time to start discussions and what to expect in the perimenopause and menopause stages of life?
That's a really good question. I see a lot of people in my gynecology clinic who are just very confused, aged 44, about what has happened to their body. My periods have become really irregular. What's wrong with me? They're heavy. My energy levels are terrible. And the answer is you're going through the perimenopause. And I think it is good that this government funding has come through, that as the start of the, building upon that awareness of women knowing more about their own bodies, GPs knowing about how to look after them and have those conversations. When is a good time to talk? I suppose when women are coming in for smear tests, how is your cycle? We know that the menstrual cycle is such a window into your general health. And I was reading a paper the other day about the menstrual cycle is a vital sign, and it changes during our teenage years, during our 20s and 30s and our 40s. And it's telling us that shorter cycle, those cycles that are spacing out, something is changing in your body.
So can you put an age on it, a specific time that you should be asking?
That's a really good question. I think probably around about 40, most women start to notice these changes in their body and start wondering what is happening to me and having those conversations with their friends. So maybe the visit around about that time. Would you schedule an appointment for after women's 40th birthdays? That could be a good time to have that well woman check and start those conversations, especially if a package is available.
Part of the federal funding is putting some funding aside to upskill GPs who want to be upskilled in the management of menopause. We know that for a lot of us it's bread and butter, but there are some that are seeking more education. What would you like to see with that funding and that education?
I suppose I'm always a back to basics person when I have a better understanding about what it is, what the condition is, what the sort of pharmacology is of what I'm prescribing. So, I'd like to sort of have a in-depth look at the reproductive physiology at that time. I think there's lots and lots that we sort of skim over, and we can go really deep into that to then understand what's important in terms of the pharmacology, what the different types of estrogens are, how they can help, how they can't help, so you can tailor that treatment to your individual patient, and also thinking beyond the estrogens and the progestogens, the other medications that are available, and those the difficult cases, the people who are post chemotherapy, post radiotherapy, to be able to have that sort of partnership with very well trained GPs and the gynecologist, because they need a lot of support, because it takes a lot to get a good improvement for them.
And speaking of other medications, a very common question we have from patients at this age is, what can I do about my low libido? And can you please prescribe me some testosterone?
Yeah.
What is the best approach to treating a woman who has low libido, and what is the evidence when it comes to testosterone treatment?
Sure. So the evidence for testosterone treatment is for treating hypoactive sexual desire disorder. So it's for women who have a very low libido and are bothered by that. And that's when using things like the testosterone gels are the most appropriate, and we get the best results. We know that testosterone in women is a hormone that we all make, and is highest in our early 20s, declines towards the menopause, and surprisingly picks up around 65 and 70. There is no sort of therapeutic level that testosterone should be at. So in terms of it doesn't matter what it is in the blood. Some women have low testosterone and are very happy with their libido level. So it's not something that it's more how it's affecting their life rather than what their actual levels are. Firstly, sort of problems with intercourse and intimacy and libido. It's very complicated, and it's often not just due to the hormone levels. Again, we've talked about menopause being a very busy time of life. People are exhausted, people are pulled in all other ways, and often making time to have those intimate moments with partners is difficult. So when I'm approaching a patient, I suppose I'd want to know, yes, about their menopause symptoms, but also, is sex comfortable? Is sex painful? Is there any trauma history there? Has there been any history of endometriosis? Often working with a pelvic floor physio is a good first step if there is raised pelvic floor tone, or they've had chronic pelvic pain, for example. Is that the issue? Is it due to vaginal dryness? Is using different types of lubricants the right course to go down? And sort of really unpacking that complex sexual response to why the libido has gone and it's bothering them. The other thing is then thinking about how estrogen is delivered. If estrogen is delivered orally, it can block the testosterone and can take up all the sex hormone binding globulin receptors, so that although there is testosterone around, it's not as available. And sometimes switching to something like transdermal estrogen can make their own testosterone more available. So I'd probably do that first. And then for those women that are bothered by their low libido, then yes, the testosterone is there. It hasn't been very easily to be accessible for a while, making those testosterone products for women, but they are coming through. And you don't want it to be so high so they've got acne and increased hair growth. So then the blood tests are useful for monitoring that. Is that in an appropriate range, just to keep an eye on things, and the symptoms as well.
How often would you do the testosterone levels?
I think about every 3 to 6 weeks.
The Jean Howells 2023 National Women's Health Survey specifically looked at the impact of symptoms attributed to menopause by Australian women. 37% of survey respondents reported the menopause symptoms they experienced in the 5 years prior made it hard to do daily activities. 31% found it hard to work or study, 22% missed exercise, and 12% missed days of work or study.
To shift focus now, and another key part of the funding package centred on contraception. So what are the medications that have come onto the PBS in March?
Yes. So we've got two of the newer pills, which are Yaz and Yasmin. They're really useful. They're particularly good for people who are experiencing PMDD because of the type of progestogen that's there. There's lots of different types of progesterone in the pill, but these two are shown to be particularly good. The Yaz, talking about our perimenopausal patients, because it has that slightly lower estrogen dose, and we know that a lot of perimenopausal women will experience their kind of those prolonged and worsening PMDD symptoms. This can be a very helpful medication for them as long as they're safe to be on the combined pill with the usual safety netting for that.
Part of the announcement from the federal government is a package to fund more pelvic pain clinics. The MATER already has its own persistent pelvic pain clinic.
Yeah.
Can you tell us a bit about the service?
Yeah, so it's a great service, and it is, I think, our patients that have this persistent pelvic pain, it's one of those really difficult challenges because it's very complex, and I think women can often feel that they're not listened to, or it's a problem that nobody seems to get a good treatment for them for, and as they're, the GP who's looking after them over many years, it must be incredibly frustrating. And so at the pelvic pain clinic, we do take these women seriously, and we have a multidisciplinary approach. So we know that people with persistent pelvic pain, it's not just their gynecological organs, it affects their bowel, it affects their pelvic floor tone, it affects their bladder, it affects their well-being if you're living with pain for a long time. So it brings everybody together. So we have a gynecologist, we have a psychologist, we have a gastroenterologist, we have physiotherapists, we have pain specialists. So we're bringing everybody together to think about what is it, how can we help, how has it gone to other areas in your body that's reflecting the, exacerbating, continuing the pain that's there. So the pelvic floor physios, they work with release of those areas, stretches, things to help with bowel regulation, bladder regulation. Our gastroenterologists will talk about people who then have very sensitive bowels and disturbed guts due to that, so I can work with them on their sort of biofeedback loops to improve those sorts of things. And the gynecologists are there doing what we do, normally checking for, is there anything we can help with hormonally? Are there anything topically we can use? So it's really satisfying when people come back and say, actually, this has made a difference, but it needs to be taken seriously, and it needs everybody to have a good look and a good think about how we can help.
Is there anything else on the horizon medication-wise that you think we should know about?
Yeah, so when I went down to the menopause conference down in Melbourne a few months back, they were talking about fezolinetant, which is an exciting new treatment for vasomotor symptoms, for those hot flushes, which doesn't involve hormones. And the research has been done on these CANDI receptors in the brain, which become more sensitive to the changes in heat. And this medication is targeted on that so that it sort of just calms down a bit and doesn't send off these hot flushes all the time. It doesn't involve hormones. It's very good for vasomotor symptoms. It's not good for bone density, vaginal atrophy, all the other things that we worry about. Often sleep is mainly affected by those vasomotor symptoms, so it can help with that. But it's a different way of approaching apart from MHT. It's
not on the PBS?
Yeah.
But it is TGA approved?
It is, yeah. So hopefully that's something that we'll be able to use for our patients in the coming future.
It's so interesting. Melanie, thank you so much for joining us on sMater and sharing with us the updates on women's health and funding. But before you go, we've got something that we call the checkup. So we're going to ask you 5 quick questions, and it's to learn a little bit more about Melanie the person as opposed to Melanie the doctor. Sure. So Maria's going to ask you some questions. Are you ready?
I'm ready.
Okay.
If you weren't doing this, what would you be doing instead?
I would be writing comedy scripts.
For television?
Yeah, wherever they'd have me. Yeah, that's what I would be doing. Very different.
It's very different.
And speaking of writing, how do you describe your handwriting?
Oh, variable, I think, is my handwriting. I'm a lefty, which doesn't help to begin with, and I'm a doctor, so I try really hard, but...
What TV show best portrays your profession?
Probably This Is Gonna Hurt, but that's a very dark side of it. The joy I would experience is probably more like scrubs. Yeah.
That's a nice way to put it.
Yeah.
Do you have any superstitions?
Do I have any superstitions? Oh, yes. If it's a stormy night or it's a full moon, then labour ward's going to be busy.
And how do you want patients to see you?
I'm somebody who's approachable, that can ask many questions, and hopefully I'm somebody that explains things to them so they have an understanding of their bodies and they're empowered by the conversations they have with me.
That's what exactly you've done today. So you've been fantastic. So thank you so much once again for joining us on sMater.
Thank you.
For our listeners at home or in the car or having a well-deserved break between patients, thank you for tuning in.
See you next time on sMater.